I think it's helpful to think of the setting of a resident or internist in clinic seeing a patient with leg pain. And from your perspective, when is it important for that provider to keep PAD on the differential?
When I was in training, and how I was always taught was claudication, which is cramping of the leg when someone ambulates and it's relieved with rest, really defined peripheral artery disease. Now, obviously, there's the more extreme form where people have pain at rest and ulcers and gangrene. But, I think that the teaching about claudication was a little inaccurate because we know that more than 50% of patients with peripheral artery disease do not have classic symptoms of peripheral artery disease. So again, claudication being ambulating with pain relieved with rest, a lot of patients come in with a feeling of heaviness in their leg, tingling in their leg, feeling like they're have poor sensation in their distal toes. So all of these kind of what was claimed to be atypical symptoms, we found that really are actually more representative of peripheral artery disease symptoms than the classic claudication. And we've heard a similar story with chest pain, as we know that can be very different based on who you are and your makeup. And so I think that a person that has any of the traditional risk factors for peripheral artery disease with a leg symptom really deserves some investigation of whether this may be peripheral artery disease.
And then just to be like very explicit, when you say the traditional risk factors, can you speak to what those risk factors are?
Absolutely. In my mind, there's three big ones. So when we see our patients with peripheral artery disease, patients tend to have either one or more of the following: diabetes, tobacco use, ongoing or prior, or chronic kidney disease. So those three really tie in strongly to peripheral artery disease and outcomes. And then there's the other risk factors we think of: high blood pressure, hypertension, hyperlipidemia, and some other risk factors depending on age and whether you're male or female. The one thing that is unique, though, is men and women in particular, after your sixth decade, tend to present with pretty similar prevalences of peripheral artery disease. So we don't look at it like coronary disease, where premature coronary disease is different for a man and a woman. Most of our patients with PAD come in after the age of 50, and there's a very equal prevalence between both genders at that point.
Okay, that's super helpful. Then maybe just speaking a bit about clinical features that help distinguish PAD from other kind of like other diseases that might present similarly, like venous insufficiency or spinal stenosis.
Yeah, so another great one. So again, I had a patient on Friday, classic referral. Patient comes over, really reproducible leg symptoms with ambulation, not a ton of risk factors, wasn't a smoker, had high cholesterol, but again, she was like in her early mid 60s. And, she was telling me and describing that med school textbook, the USMLE question. I go to the grocery store and I lean over on the cart and I feel so much better and I can push my cart and then I stand up or I carry my groceries and that's my leg symptoms are back. And the first thing I question is, have you had orthopedic issues? Have you ever had an x-ray of your spine? And typically what I'll do at that point is complete my vascular workup, but at the same time, send for a plain film of the spine. And sometimes even I'll send over either to ortho or our pain group just for even a consideration if there is spine disease for an injection for us to tease out if this is PAD or not. Because again, a lot of times I'll have some mild PAD and some spinal disease as well. And so that one comes up a lot also of neurogenic claudication. Again, it's always easier if they have no PAD. If I feel bounding femoral pulses and there are no clear risk factors, and then they have this pattern of bending over and feeling better, it's a much clearer picture. It's usually a little bit more muddy where you have a little bit of each and you got to figure out which is the main contributor. In terms of venous disease, the nice thing about venous disease is that there's typically the peripheral symptoms that are clear on the exam when people have true limb pain from venous disease. So typically they either have big bulky varicosities, and those can be painful, itchy, and heavy, and particularly at the end of the day. And then obviously edema, in particular dependent edema that might progress throughout the day, especially for workers who might be standing up all day and notice that by the end of the day that their legs are swollen and tight and heavy. So the classic venous disease findings tend to be predominant in those patients. And again, we always want to rule out concomitant peripheral artery disease. So typically, if they really have limb heaviness, pain, or ambulatory symptoms, even though I feel like on their exam it might be primarily venous disease, I'll still check an ABI and make sure that there is no concomitant peripheral artery disease, because we know that there can be mixed processes very often.